Good evening, everyone. My name is Egina Francis Makwabe. I'm the consultant physician and nephrologist working in Tanzania with Africa Healthcare Network. I'll be sharing this session together with Dr. Frida Mowo, who is a consultant pediatrician and nephrologist working with AHN as well, and Dr. Jonathan Wala, consultant physician and nephrologist working with Aga Khan Teaching Hospital in Kenya, Nairobi. So I would like to welcome you all to today's AHN Nephrology webinar, and today's series number 85. So our topic today is renal transplantation in HIV. And this is a very interesting topic, and will be covered by Dr. Ramesh Prasad. Dr. Ramesh Prasad obtained his MBBS medical degree from Osmania University, Hyderabad, India. He completed his internal medicine residence at Wayne State University, Detroit Medical Center, nephrology fellowship at the University of Pittsburgh Medical Center, and transplantation nephrology fellowship at Toronto General Hospital. He holds an MSc degree from the Institute of Medical Science, University of Toronto, plus MA and PhD degrees in philosophy from the University of Waterloo. He's a staff nephrologist and director of the kidney transplant program at St. Michael's Hospital, professor of medicine at the University of Toronto, and a fellow of the Royal College of Physicians of Canada, American Society of Transplantation, and the American Society of Nephrology. Dr. Prasad has a special clinical and research interest in different areas. So with these few remarks, I would like to welcome Dr. Prasad to continue with the presentation. Welcome, Dr. Prasad.
Thank you, Dr. Makwabe. It's really an honor and a pleasure to present to your group today. So the topic that I was asked to speak about is our experience with kidney transplantation in the context of HIV infection. And so for the next 30 to 40 minutes, I hope to discuss all aspects related to how these two common clinical conditions intersect. So there's been a lot of development over the last 20 years at our hospital. These are pictures of our hospital taken one about 15 years ago when Dr. Vincent was here, and then what it looks like more recently with the addition of more wings, more ICUs, more wards, and an expanded space for nephrology as well. So it's really an exciting and dynamic place to work. And as you mentioned before, we have 4 major teaching hospitals in Toronto, with St. Michael's being one of them. It's not the largest of the 4 hospitals, but I consider it to be in the what we would call the Goldilocks zone, the right amount. It's large enough that almost every specialty is covered, but it is small enough that the staff physicians largely know each other, and the communication between individual departments is quite good. So we have a nice mix of sophistication and simplicity. So this is a snapshot of our program. So I'm always happy to point out to my dialysis colleagues how many more patients we see than my dialysis colleagues see in their programs. So each colored bar here represents a calendar year. This goes from 2006 to 2020. And you can see that the total number of transplant patients that we take care of, that we provide long-term care to, is much, much more than the number of in-center hemodialysis patients or the number of home dialysis patients. So we perform approximately 120 kidney transplants per year, all adult, all single organ. And the split between deceased donor and living donor is roughly 60 to 40 or 70 to 30. The number of living donor transplants varies from year to year. At the end of 2021, we were taking care of close to 1,800 patients. Our long-term graft and patient survivals are at the national average or slightly exceed that. Now, COVID is not a topic for today's presentation, but at the onset of the COVID pandemic, we temporarily closed activity, but only for a very brief period of time, maybe 2 or 3 months in 2020. And after that, activity has increased, and now it is back to normal. We've learned to live essentially with COVID. So coming to HIV infection, in the early days in the 1980s, and I'm old enough to remember that, HIV was quite a scary phenomenon. It used to be considered a condition that invariably led to death, maybe within a few years, maybe after many years, but that would be the ultimate outcome. But nowadays, HIV is nothing more than a chronic manageable infection, and the life expectancy of patients with HIV is quite reasonable. Similarly and simultaneously, there has been a marked improvement in long-term patient survival for patients with end-stage kidney disease who require renal replacement therapy. Because dialysis is available as a life-sustaining renal replacement therapy for patients, and in healthcare systems that can afford it, almost everybody is offered dialysis, and that includes HIV infected patients. So we have a combination of improved survival with HIV and improved survival with renal replacement therapy. And as a result, kidney transplantation is now being considered as a viable option for end-stage kidney disease patients with HIV infection. And that is something that all dialysis and transplant programs have to consider seriously as an option going forward. But there are some barriers to performing kidney transplantation in general, and these would apply also to HIV positive patients. One, of course, is the cost. Kidney transplantation is associated with a huge upfront cost, which has to be borne by national healthcare programs. Transplantation, of course, has to be available in the hospitals that seek to provide it. But specifically to transplantation in HIV, there are some drug interactions, some important drug interactions to be aware of, and we'll be going through that in some detail. There are also co-infections to deal with, and we'll be talking briefly about hepatitis B and hepatitis C co-infection in the context of HIV infection. And then, of course, there are biases that are both implicit and explicit that we have to overcome. And we'll be touching briefly upon some of these, and hopefully remove some of these biases by the end of this presentation. So we'll talk about 2 cases that we've encountered at our hospital, and we'll compare and contrast them and see if there are any lessons that can be learned from these 2 patient profiles. So the first case, the one that Dr. Vincent in our pre-presentation discussion was talking about, this is a 46-year-old Caucasian gentleman who has a history of HIV infection for many years. His end-stage kidney disease was from polycystic kidney disease, not from HIV nephropathy, and this may be an important point. He received a living donor kidney transplant from a friend. His friend was HIV negative, and this transplant was performed in 2007. The patient experienced good baseline kidney function afterwards with a serum creatinine that settled around 100 micromoles per liter. I'm not sure of the units that you use in East Africa, but that corresponds roughly to 1.2 milligrams per deciliter. There were a few complications that developed along the way. He developed post-transplant diabetes in 2008. Had some difficulty with cardiac disease, underwent percutaneous coronary angioplasty in 2011 and bypass grafting in 2016. There was good graft function maintained throughout these. The CD4 counts remained stable, and this patient was maintained. I mean, there were drugs that were started and stopped along the way, but over the last 14 years, most of that time was spent on some combination of atazanavir, which is a protease inhibitor, and travarine, which is a non-nucleoside reverse transcriptase inhibitor, and raltegravir, which is an INSTI, and we'll talk about that. There were no opportunistic infections, and as of 2022, he has not been biopsied, but has developed most likely chronic allograft nephropathy. with the serum creatinine being 237 micromoles per liter and a urine albumin to creatinine ratio of 200 micromoles per liter, millimoles per liter. The second case I'd like to discuss is a 45-year-old Black woman, and she has a history of HIV infection for many years. Her end-stage kidney disease was from HIV nephropathy, and she received a deceased donor kidney transplant offer in 2011. Now, her body size is small. She weighs only 45 kilograms, and the donor was a 12-year-old boy who had died in a boating accident. And so because of the relatively small size of the kidney, we were keen to offer this kidney to a small sized recipient. And we actually had to go down the list, about 10 or 12 positions down the list, something which we're authorized to do, but something which we don't do very often. And so we had to find a patient with comparable body size to avoid donor-recipient size mismatch. And so we settled on this lady. And her baseline serum creatinine was similarly around 100. But the main problem post-transplant was a chronic diarrhea. And despite infectious diseases consultation and GI consultation, we were never able to actually ascertain an etiology for the diarrhea. Cultures really came back negative. But she developed malaise and intravascular volume depletion despite CD4 counts that were quite stable and HIV viral counts that remained very, very low. And the main drugs that were used were ritonavir, which is a protease inhibitor, lamivudine, which is an NRTI, and raltegravir, which is an INSTI. So some combination of these drugs. But unfortunately, the graft failed in 2014. So what we'll talk about over the course of the next few minutes is the eligibility and the evaluation of patients for kidney transplantation. We'll talk about some results that have been reported worldwide. These are not our results. Our patient numbers are very small. These are from large databases and from other transplant centers, mostly from South Africa. And then we'll talk about managing the graft post-transplant, managing the HIV infection post-transplant, what is required in terms of post-transplant monitoring. We'll talk about the management of co-infection. And more recently, people have begun to use HIV positive donors. And so we'll talk a little bit about that as well, both in terms of recipient outcomes, as well as in terms of donor safety. And then we'll finish with a summary and some conclusions. So consider this a broad overview of HIV infection and transplantation. So the initial experience with transplanting HIV positive recipients comes out of South Africa. And the first major publication in this area came out in the New England Journal in 2010. And so the criteria that were set forth for accepting patients for kidney transplantation would include an undetectable viral load, a CD4 count of at least 200 cells per ml, and on stable antiretroviral therapy for at least 6 months after the transplant. Occasionally, there can be viral blips in just about every HIV positive patient. And so if these blips result in less than 200 copies per ml, then that is considered permissible. But there are some exclusion criteria. So a history of Kaposi sarcoma, a history of CNS lymphoma, and a history of progressive multifocal leukoencephalopathy would be definite exclusion criteria for kidney transplantation. If there are a few opportunistic infections other than these, then those would be considered permissible. And also if there are occasional drops in the CD4 count or rises in the viral count, as long as they're below 200, then that would be considered permitted. Consultation with an infectious diseases specialist is strongly recommended. And if there is co-infection with hepatitis C or hepatitis B, then in addition, consultation with a hepatologist and an assessment for the degree of liver fibrosis would be strongly recommended as well. And so what should be done in terms of evaluating a patient before kidney transplantation? The patient has to go through a screening that is applicable to every kidney transplant recipient, every potential kidney transplant recipient. But in addition, there must be a screen for latent tuberculosis, even in countries where tuberculosis is not endemic. So in Canada, at our hospital, at St. Michael's Hospital, we actually screen our patients for latent tuberculosis with a skin test, a PPD skin test. If it is positive, then there is always the concern that this may be related to prior BCG vaccination. If that is the case, then we will do an immunoassay, what we call an IGRA. And if that is positive, then we offer the patient therapy for 6 months prior to putting them on the kidney transplant waiting list. So here with HIV, this would include just about every patient, just as we do at our hospital. All vaccinations must be up to date, so it is important to obtain a detailed vaccination history. One should also obtain a detailed viral load history and a CD4 cell count history, as well as a detailed antiretroviral medication history, because this is a good opportunity to modify the antiretroviral medications in a way that is most friendly to the kidney allograft without having to deal with serious drug interactions afterwards. One should obtain an opportunistic infection history and a malignancy history. And it is best to engage with an infectious diseases consultant beforehand. And in your transplant program, if you have a pharmacist, you should engage the pharmacist before the transplant as well, in order to get advice about potential drug interactions that you will deal with post-transplant. And then if a transplant program does not have prior experience with transplanting HIV positive patients, then it is recommended that a relationship be established with a transplant center that has experience in transplanting HIV positive patients. And this should all be established beforehand, before performing the first kidney transplant at your center. So now we'll talk a little bit about results. So this is from the Stock paper, which the data is now 12 years old. And the bottom line really is that there is excellent patient and graft survival. So if you look at the 150 HIV positive kidney transplant recipients who were studied here, the 1-year patient survival was 94%. And that compares favorably to all the patients in the SRTR, the Scientific Registry of Transplant Recipients from the United States, where it was 96%, 94 versus 96% 1-year patient survival. And in the older age group, over 65, generally speaking, for end-stage kidney patients who get a transplant, you would expect their patient survival to be slightly less, and it was 91%. So the HIV positive patients at 94% is actually better than the all-comers over 65 age group at 91%. This is the 3-year patient survival. The numbers here, 88 compares favorably to 90%. And in terms of graft survival, the 1-year graft survival, again, is excellent, 90% versus 92%. 5-year graft survival, a little less, but still very good, 73 versus 82% for all patients in the SRTR registry. So this paper that came out about 5 years after that looked at the effect of hepatitis C co-infection with HIV infection. And so the panel on the left side compares the graft survival in patients with HIV, HIV positive patients, to those who are hepatitis C negative. And you can see here, the results are 5-year graft survival is quite comparable. The p-value is insignificant. Now, if you compare this to patients who are hepatitis C positive but HIV negative, so this control group is hepatitis C positive, HIV negative, then their graft survival is actually better than those who are co-infected with HIV and hepatitis C. So you can look at this both ways. You can use 2 types of controls for HIV positive kidney transplant recipients. You can use those who are HIV negative, that's an obvious group. But even those who are hepatitis C positive without HIV, if you use them as a control group, it appears that there is an adverse impact of HIV on the survival of hepatitis C positive patients. And so this advises caution when transplanting hepatitis C positive, HIV positive recipients. This is death-censored graft survival, and the p-values here are non-significant. The reasoning behind this is that HIV positive patients are going to die from causes unrelated to the transplant failure, and so their impact is minimized. And this is patient survival, which shows that the 5-year patient survival in HIV positive patients is 67 versus 78%. But compared to hepatitis C positive patients, this is significant, 29 versus 56%. So special caution is advised in the presence of hepatitis C co-infection because their survival is inferior if they're dually HIV positive, hepatitis C positive. But if they're hepatitis C negative, then the survival is quite favorable. So how do we manage their immunosuppression? So both ATG and basiliximab can be used in HIV positive patients, and I'll show you some data to show that there is no fear with using lymphocyte depleting agents such as ATG. Both cyclosporin and tacrolimus can be used. However, tacrolimus is preferred to cyclosporin because of a lesser acute rejection rate. There are no concerns raised with regards to using mycophenolate mofetil or mycophenolic acid in HIV positive patients. Of course, one has to monitor cell counts and so on. Perhaps because MPA largely replaced azathioprine before we started transplanting HIV positive patients, there is very little data on azathioprine. We still use azathioprine in some patients with refractory symptoms related to MPA, but there's no data on its safety. It's also important not to avoid steroids because there is an increased risk for acute rejection as a result. And with regards to sirolimus, there's really no data, no large data, but there may be a higher risk of acute rejection. There is a concern about opportunistic infections. So this data that was published about 5 years ago, 6 years ago in the American Journal of Transplantation looks at various therapies and how they resulted in different opportunistic infections. So the blue bars indicate no induction therapy. ATG is shown in the red bars here. Basiliximab is shown with the green bars. A combined therapy shown in the yellow bars, and then others. And you have urinary tract infections, sepsis, AIDS-defining illness, pneumonia, CMV, intestinal infections, candidiasis, Clostridium difficile infection, herpes viruses, and RSV. And there really is no statistically significant difference among these with regards to the opportunistic infections that one might worry about seeing in HIV positive kidney transplant recipients. So really no difference between ATG and basiliximab is the main message here. Looking at their data a little further, the blue lines indicate no induction therapy. The red lines indicate induction therapy. So this is a study of over 800 patients, and they showed that patients receiving induction therapy spent fewer days in the hospital, about 30% less, with a relative risk of 0.70, lower delayed graft function if induction therapy is used, and lower acute rejection rates with almost half. So you see here the 1-year censored graft loss and the 1-year mortality, which if anything is better with the use of induction agents. And like I showed you in the previous graph about an increase in infections, there was no increase. And the relative risk, if anything, was actually below 1, not above 1. So absolutely no concern about using ATG or basiliximab in kidney transplant recipients who are HIV positive. And the message from this paper was induction therapy should be strongly considered in HIV positive kidney transplant recipients. This is the one paper that came out comparing tacrolimus and cyclosporin. So I'm not sure how it is in Africa right now, but in most parts of the world, tacrolimus has replaced cyclosporin as the calcineurin inhibitor of choice in kidney transplantation. And so this is a paper looking at 78 patients, all HIV positive who received a kidney transplant, and they followed acute rejection rates over a year. And you can see that the acute rejection was 21% with the use of tacrolimus and 58% with the use of cyclosporin. And so now it's almost mandatory to use tacrolimus as a CNI if you are going to be transplanting HIV positive patients. So no problem with using induction therapy, ATG, no problem with using ATG, and one should use tacrolimus rather than cyclosporin. Steroids, it's better to use. There's always a concern about worsening HIV infection if one uses prednisone, and as you know, we use large doses of prednisone in the first 1 or 2 months post-transplant. But we do bring the doses down fairly quickly. So by 2 months post-transplant, our prednisone dose is down to 5 milligrams per day. And some patients do require more if they develop acute rejection, of course. But if you try to avoid steroids from the outset, then you are dealing with an increased acute rejection rate. So this is a very small study, but because this question is so important, the paper made it into Transplant International, and it showed that 60% of these patients developed acute rejection by 4 years post-transplant. So you do have to deal with increased rejection. And if you remember here, our standard really is around 20% for acute rejection. Whereas if you avoid steroids, you're dealing with a 60% acute rejection rate. And of course, the treatment for that acute rejection requires enhanced immunosuppression. Not only does it risk graft loss, but it also risks opportunistic infections that can occur as a result of increased acute rejection therapies. So best to avoid that upfront and use steroids post-transplant. So that is an overview of the anti-rejection medications. So now we'll talk about the HIV medications themselves and which HIV medications should be used in the post-kidney transplant setting. So this is a useful slide that looks at the mechanism of HIV infection and HIV virus proliferation and how the different anti-HIV medications work. So you have the HIV virus here, the viral particle. The viral particle binds to the cell membrane of the host cell. And the way the virus enters the cell is predominantly through the CCR5 or the CXCR4 receptor. Once the virus enters the cell membrane completely envelops the virus. The viral RNA is released, and under the influence of reverse transcriptase, the viral RNA is turns to viral DNA. Viral DNA then enters the host cell nucleus. It is integrated, and then it is transferred into the host cell DNA through the integrase strand transfer. The DNA is then transcribed, translated into RNA again. The RNA translates into viral protein, which forms this viral core structure after being assembled. This goes back to the host cell membrane and then is integrated into a full HIV viral particle with the help of proteases. And then a new HIV viral particle is released after it matures. And so the drugs that are used to combat HIV infection target different aspects of this mechanism. So there are CCR5 antagonists that are being developed, and we'll briefly discuss one of them. And then there are attachment inhibitors and post-attachment inhibitors as well. Some inhibitors of fusion. We won't be going into these because they aren't fully developed, but most importantly are the reverse transcriptase inhibitors, which are broadly of two categories, the nucleoside analogs and the non-nucleoside reverse transcriptase inhibitors. And one of my patients was on an NRTI, the other one was on an NNRTI. And for discussion purposes, these are similar clinically. And then the integrase strand transfer inhibitors, which are an important part of management, and then the protease inhibitors as well, which we'll talk about. So the first drugs to be used in HIV positive kidney transplantation were the protease inhibitors. And so this is a case report that came out in the early days of HIV positive kidney transplantation, where the patient was on tacrolimus, on the Prograf, twice daily preparation of tacrolimus, and was started on a combination of nelfinavir, stavudine, and lamivudine. And as a result, the tacrolimus level went up markedly, up to 120 when the patient was also on these drugs. So these drugs were stopped and the tacrolimus level came down. So about 11 days after these drugs were stopped in the hospital, the patient's tacrolimus level came down to a more reasonable therapeutic range around 10 nanograms per milliliter. And the Prograf dose was reduced markedly from 4 milligrams twice daily to 0.5 milligrams once every 3 days. And one of the two patients that I mentioned, the one with the polycystic kidney disease, was actually maintained on ritonavir 0.5 milligrams every second week in order to maintain the tacrolimus level in the therapeutic range. So protease inhibitors are, they very, very significantly interact with the calcineurin inhibitors. And these are the protease inhibitors you might come across. Atazanavir and ritonavir are the most common ones, but I have seen some patients on darunavir, saquinavir, tipranavir, indinavir, we all know as being an nephrotoxic drug, and nelfinavir. And so the overall recommendation is that in HIV positive kidney transplant recipients, you should avoid protease inhibitors wherever possible. In addition, it is important that atazanavir has an important interaction with proton pump inhibitors. And so there is the danger that the efficacy of atazanavir is reduced, and this might impact your HIV management. So that's important to keep in mind. And ritonavir, as I mentioned in our case, is a potent cytochrome P450 inhibitor, and then therefore has significant interactions with the calcineurin inhibitors. Now, integrase strand transfer inhibitors, or INSTI, are a very promising medication. And this paper from American Journal of Transplantation 2009 is the basis for the popularity of INSTI in transplant recipients. So this is a case series of 13 HIV positive patients who received raltegravir, which is an INSTI. And for these 13 patients, they were able to maintain standard CNI doses and maintain therapeutic CNI levels over at least 9 months of follow-up. And they also saw no acute rejection. And not only was there no relapse in HIV itself, but they were also measuring raltegravir concentrations, and they were able to demonstrate therapeutic raltegravir concentrations as well. So all in all, this was a very successful therapy. So this is a table that I put together based on the literature and what I would recommend for using antiretrovirals in HIV positive kidney transplantation. So you should always use 3 medications, 2 of which should be an NRTI or an NNRTI, and 1 of which should be an INSTI. So avoid protease inhibitors wherever possible. Now for the NRTIs, for your first drug, you have a choice between tenofovir and abacavir. Within tenofovir, there are 2 preparations. One is TAF, or tenofovir alafenamide. And then more recently, you have TDF, which is tenofovir disproxyl fumarate. So I don't know which ones are available in Africa, but nowadays in Canada, TDF is becoming increasingly popular compared to TAF. Now, the advantage of TDF over TAF is that TDF can be used if the GFR is less than 30. So many of our transplant recipients have GFRs which are in the 50 to 60 range, which would be ideal. but there are some who have rates that GFRs that are lower than that. And if you start the patient on TDF up front, you don't have to switch them to TDF from TAF if their GFR declines over time. If one does not have tenofovir, then one can use abacavir as well. The one concern with abacavir is that in Caucasian patients who are HLA-B5701 positive, it could lead to marked toxicity. And so it's only 1%, but it is something to be aware of. But either tenofovir or abacavir should be good as your drug number 1. Drug number 2, you have a choice between emtricitabine and lamivudine. Lamivudine is often used in hepatitis B infection, and so that might be preferred if that's the case. The thing to remember with lamivudine, though, is that it may cause lactic acidosis, especially if the GFR is lower, but it can be used. Emtricitabine has become a drug of choice, again, mainly because it can be used if the eGFR is less than 30. Your third drug, you have a choice among dolutegravir, raltegravir, or bisetegravir. Dolutegravir has the advantage of being used again if the GFR is less than 30, and it's quite popular. And as I mentioned before, it does not interact with the cytochrome P450 system. Raltegravir does have some interaction. And so with INSTIs in general, you do have some increased CNI dose requirement, but that's something we can deal with. So you might say that it's not a clinically significant interaction as long as you're measuring CNI concentrations. And we'll talk about that as well in a couple of slides. So tenofovir, preferably TDF or abacavir, plus emtricitabine or lamivudine, plus dolutegravir or raltegravir. Which drugs you choose ultimately will depend on which drugs are available in your country, what the preference of your infectious diseases specialist is, and also the availability of combination therapy, because many of these drugs are available in combination. And so reducing the total pill burden is preferable and advisable. And so your ultimate choice might be dictated on which combinations are available in your country. Then different brand names and combinations are too numerous to go through today. How about other drugs in HIV positive kidney transplantation? So sobicistat is a medication that is a potent CYP3A4 antagonist, and so might be used potentially to boost protease inhibitors and integrase inhibitors. It will reduce CNI dosing requirements significantly. So as long as you know what you're dealing with, I wouldn't recommend ritonavir for this purpose, but if you can adjust the dose of sobicistat in order to reduce CNI dosing requirements in places where CNIs are very expensive, then that is something to consider. So in our place, we have used diltiazem as a CYP3A4 inhibitor to reduce CNI dosing requirements. And I know in India that has been done in the past. So this is something to consider, but I'm not aware of any actual clinical experience, published clinical experience with sobicistat in HIV positive kidney transplantation. Maraviroc is an interesting drug because it is a CCR5 inhibitor. And if you remember the diagram, CCR5 is required for the HIV viral particle to enter the host cell. And there are groups of HIV resistant individuals, patients who are multiply exposed to HIV as part of their professions. And they have mutations of CCR5, or they have anti-CCR5 antibodies, which actually prevents the HIV virus from entering the cells. And so they don't develop clinically significant HIV infection. And so Maraviroc inhibits CCR5 and may be used for that purpose. It does not affect CNI concentrations. It's unlikely to affect acute rejection rates. And there is an ongoing clinical trial using Maraviroc in HIV positive kidney transplant patients. So we'll see where that goes. So Maraviroc might be here as the entry point for CCR5. Reverse transcriptase inhibitors. So you have your drugs here. You have the choice of tenofovir, dolutegravir, abacavir, etc. You have the integrase strand inhibitors, and then you have the protease inhibitors. So you have various points along the cascade that you can use in treating HIV infection. And at each point, we've talked about how they might interact with the CNIs and drugs that you use specifically for the kidney transplant. So how about HIV co-infection with hepatitis B or hepatitis C? Patients with HIV are at increased risk for having HBV or HCV infection, and they are also at increased risk for developing HBV or HCV infection post-transplant. So that's very important to keep in mind. With hepatitis B, tenofovir, the TAF form, the older form of tenofovir, is considered the drug of first choice. So remember, I told you that TDF is replacing TAF, mainly because it can be used at an eGFR of less than 30. But the literature suggests that if there is hepatitis B co-infection, then TAF becomes the drug of first choice. Now, both TAF and TDF are mildly nephrotoxic, and they're associated with decreased GFR if they are used for more than 5 years. This is in non-kidney transplant patients. But entecavir, which is a newer agent, is supposedly less nephrotoxic than tenofovir. And because long-term graft survival rates are inferior with hepatitis B and hepatitis C co-infection, it might be good to remove the nephrotoxicity element of that. And so entecavir might be preferred over tenofovir. And we actually have a few kidney transplant candidates at the moment where our infectious diseases specialist has suggested converting them from tenofovir to entecavir because of less nephrotoxicity. For hepatitis C, it might be advisable to eradicate the hepatitis C infection prior to kidney transplantation by using this combination of ledipasvir and sofosbuvir. Of course, they're end-stage kidney disease patients, so you're not worried about nephrotoxicity so much. But if you can eradicate the hepatitis C infection, that would be ideal. But you can also use it post-transplant for hepatitis C, because we do have patients who were transplanted many years ago with hepatitis C infection before lepidosvir and sofosbuvir became available. And now they're being treated with a 12-week course of ledipasvir and sofosbuvir to eradicate the hepatitis C infection. What is important, though, is that you do not interrupt the antiretroviral treatment because there is some concern about cumulative toxicity when you're using the drugs for hepatitis B and C along with your standard antiretroviral therapy, but the recommendation is not to interrupt that. And there may be a temptation to tinker with the post-transplant immunosuppression as well, and that also is not advisable. And always consult with an infectious diseases specialist. Post-transplant monitoring is the same as for other kidney transplant recipients. At minimum, must use CBC electrolytes, creatinine, and CNI concentrations. CNI concentrations may need to be monitored more frequently, and therefore access to a reliable lab is required. The recommendation is that HIV viral load and CD4 count be measured monthly for the first 3 months, and then at least once every 3 months thereafter. It is important to routinely screen for hepatitis B and hepatitis C as well. And I would suggest monitoring for the development of hepatitis B and hepatitis C on an annual basis post-transplant. And we use pneumocystis prophylaxis once, 3 times a week for 1 year post-transplant. But for HIV positive patients, you should consider lifelong PJP prophylaxis. So long-term threats to patient and graft survival come from multiple sources, leading to either patient death with graft functioning or with graft failure. And you'll be dealing with all of these as well as part of your post-transplant monitoring. This is our schedule. This is one example of a schedule. Obviously, it is dictated by resources as well. And so blood work we do twice weekly in the first month, We continue that up to 3 months, but the clinic visits go down from weekly to once every 2 weeks to monthly. And by 2 years after the transplant, patients are coming to clinic once a year, and they're providing blood work once every 3 months. But we may ask our HIV positive patients to continue doing blood work once a month. And this is just a table for your own reference later about all the things that we measure post-transplant, cholesterol levels, BK virus titers, we measure BNP, and so on and so forth. BK we measure up to 5 years post-transplant. This is just for your information. How about using HIV positive donors? The major experience comes from South Africa. And so for donors to be approved who are HIV positive, these donors had to have received first-line ART therapy or no therapy previously. In other words, you don't want donors with HIV drug resistance. Donors had to have undetectable HIV viral loads, no history of clinical AIDS, tuberculosis, or sepsis. And the South African experience suggests that the kidney biopsy has to be normal if a deceased donor is to be accepted. For recipients, HIV positive recipients have to meet the standard criteria for receiving a kidney transplant. They have to have low or undetectable HIV viral loads, but the experience suggests that they continue to have very low or undetectable HIV viral loads post-transplant. Rarely they would detect low levels of donor-derived HIV. So this is not a common phenomenon, and one need not be worried too much about the transmission of donor-derived HIV into the recipient. 5-year graft survival was 84%, death-censored graft survival 79%, and acute rejection rates 44%. Of course, the N is relatively small, only 50 patients, but we're dealing, as I showed you earlier, anywhere between 20 and 60% acute rejection rates in kidney transplantation. With HIV positive donors, it's right in the middle of that range, so about 44%. So you don't have to worry about acute rejection or patient survival or death-censored graft survival when using HIV positive donors. And these are outcomes in HIV positive to HIV positive kidney transplantation. This is graft survival, which is excellent. At 10 years, it is close to 80%. This is patient survival, which is close to 70%. And you can see here the yellow bars and the blue bars indicating donor viral proviral DNA sequences. The blue bars representing the same sequences in the recipient, and the bars are almost identical. There are only 2 patients reported here where there's possible donor superinfection on top of the recipient's HIV infection. So very, very promising results. And this data has been adapted in the United States. The United States passed the HOPE Act in 2013, the HIV Organ Policy Equity Act. And this act permits research into HIV positive to positive transplantation. And under the HOPE Act, 3 years later, in 2016, the United States performed its first deceased donor transplant. There was a multi-center pilot study of 25 recipients compared to 50 controls, demonstrating equal 1-year patient and graft survival. But there was a higher acute rejection rate, 50 versus 29%. And so deceased donors do not have to have a CD4 count or viral load requirement, but there should be no opportunistic infection, and they require a kidney biopsy. So based on this experience with deceased donor transplants, the United States performed its first living donor transplant in 2019. And so these are the criteria under the HOPE Act. So CD4 count over 500 in the living donor, HIV viral load less than 20 copies, no prior opportunistic infections, and kidney biopsy. For the program, there has to be prior experience with HIV positive transplantation. ID specialist support has to be available. They have to have excuse me, standard operating procedures for safe organ handling, a biohazard plan, IRB approval, and an approved variance from UNOS to be able to do these transplants. So the blue lines here indicate the positive recipients compared to those negative. And you can see here that graft survival almost identical, rejection-free survival a bit less, and rejection-free survival by type of induction is shown here, with induction therapy being superior. So 14 centers, 75 patients, 1 year graft survival, 91 versus 92%, EGFR 63 versus 57, HIV breakthrough 4 versus 6%, opportunistic infections 16 versus 12%, acute rejection not significant, but higher, 50 versus 29%. But if ATG is used, the rejection rate is only 21% versus 44%. And so the conclusion from this paper was outcomes are excellent, but the higher acute rejection rate merits further investigation. How about safety to the HIV positive living donor? Obviously, you do not want to cause harm to the HIV positive living donor. And so this group calculated the ESRD risk in almost 42,000 HIV positive patients without kidney disease, followed for 5 years. And then they determined risk associations for the cumulative incidence of end-stage kidney disease at 9 years based on their characteristics. So the risk of end-stage kidney disease in white women is 2.5 per 10,000 if HIV positive, 1.1 versus 10,000 if HIV negative. Risk for end-stage kidney disease at 9 years in white men, 3 per 10,000 if HIV positive, 1.3 per 10,000 if HIV negative. For Black women, 13 versus 3.6 per 10,000 over 9 years. For Black men, if HIV positive, 15.8 per 10,000 versus 4.4 per 10,000 if they are HIV positive. And so the risk for HIV positive patients becoming end-stage kidney disease is there. It is certainly higher than non-HIV positive patients, but overall the absolute rates are still very low. And therefore the conclusion for this paper was that HIV positive individuals may be considered low-risk candidates for kidney donation. So to summarize and conclude, carefully selected HIV positive patients can be safely transplanted. Outcomes may be inferior if end-stage kidney disease is due to HIV nephropathy. Remember, I compared 2 patients, one with polycystic kidney disease who happened to have HIV, who did very well, and 1 patient with HIV nephropathy who did not do so well. HIV positive recipients are at higher risk for acute rejection, anywhere between 20 and 60%. Tacrolimus may be superior to cyclosporin. You should avoid steroid avoidance. I recommend using steroids. ATG can be safely used. Use a 2-drug NRTI combination plus an INSTI for HIV infection. Continue other antiviral therapies in consultation with a hepatologist and ID specialist. Results in recipients from HIV positive donors are encouraging, and safety results in HIV positive living donors are encouraging as well. So hopefully this has provided an overview of how we should proceed with transplanting HIV positive recipients in your program. So I will stop there. Thank you, and I'm happy to entertain any questions.
Thank you so much, Doctor, for the wonderful presentation. I'll be chairing the question sessions. So we will start with the chat section, where I could say a lot of people have asked about tenofovir. I'll start reading one by one. From Dr. John Philip, he's asking, in use of TDF in patients with EGFR less than 30, what about the risk of tubulopathy?
Yes, there is definitely that risk, and that is why entecavir may be a better option. Both TDF and TIF are equally nephrotoxic, but the literature suggests that it's only seen at 5 years. If EGFR is less than 30, obviously you're concerned about loss of their remaining GFR. So entecavir may be preferred in that situation.
Okay, thank you. Dr. Nyandu is also asking, I would like to ask what was the first line for the patient who has HLA-B5701 positive and for a patient who is on TDF with a sign of nephrotoxicity?
Yeah, I don't have access to that data. It just came across in my literature review, but I expect the number of patients with that particular genotype is low. So not enough to make conclusions in the context of transplantation for sure.
Okay, thank you. Dr. Peace is asking, how do you monitor TDF toxicity and at what point do you switch to non-TDF based regime?
So this is not something I handle as a transplant nephrologist. My goal here is to manage the transplant immunosuppression safely. I leave the ultimate decision to the transplant ID specialist to manage the antiretroviral medications, but I do know that they are moving slowly away from TAF to TDF and from TDF to entecavir, but it's a constant communication. And certainly as a nephrologist, I do not feel confident to adjust the antiretroviral medications in my patients.
Okay.
So very, very important to have an ID specialist with you.
Yes, we agree on that one. Dr. Mazhar is saying, I would like to ask for patient 2, was drug side effect considered as a cause for chronic diarrhea? Was the patient on MMF?
Yes, that was the obvious culprit. So we did consider that first. We consider that in every patient who develops diarrhea. And so initially the dose of MMF was reduced from, I believe it was MPA, it was Myfortic. So we went from 1440 milligrams per day straight away to 720 milligrams a day, 360 twice a day. Her body size is also small, and we don't monitor MPA levels in our program routinely. Ultimately, we had to stop it. I think we did try introducing azathioprine as well, but the patient did not tolerate that well. She was complaining of non-specific abdominal pain that we didn't identify a real reason for, but eventually we stopped azathioprine as well. We were dealing with low white counts, and meanwhile all the cultures were coming back negative, and the diarrhea persisted even after stopping the MPA completely. Another cause of drug-induced diarrhea that we see in our patients is proton pump inhibitors. And so because of the large doses of steroids in the early post-transplant period, every patient is on a proton pump inhibitor. But as you know, proton pump inhibitors cause diarrhea. So that was stopped very quickly. Metformin, another common cause of diarrhea. This patient required metformin as well. That was stopped. And the diarrhea, we never really got on top of this diarrhea. She didn't have an intestinal biopsy that I'm aware of to see what the reason was, but perhaps because of a combination of chronic intravascular volume depletion from the diarrhea with chronic rejection because of we kept lowering the doses of her immunosuppression, she may have lost the graft after only 3 years. So it was unfortunately a transplant that did not work out very well.
Okay, thank you, doctor. And Mazahar is continuing to asking, is APOL1 screening considered when transplanting HIV positive patients for donors or recipients?
Sorry, what is considered?
APOL1 gene screening.
APOL1, oh. No, we have not been monitoring APOL1 routinely, but there is an emerging literature, not so much in HIV as much as in the kidney donors in general, African American kidney donors, where the APOL1 may have an adverse impact. I believe I just came back from the American Transplant Congress. There were a few posters on that. But things are complicated enough as it is with HIV. So we're not going to, I wouldn't make a decision about transplanting or not transplanting a patient based on APOL1. So it hasn't added to our management in any way.
Thank you. And Dr. Ben Lomatayo is asking if now we can transplant HIV to HIV, how about hepatitis B virus to hepatitis B?
Oh, We have never done that. I'm not aware of papers that have done that. Certainly for hepatitis C, yes. So what I can say is that in our program, we will transplant patients who are hepatitis C RNA positive, or hepatitis C antibody positive, as long as they are RNA negative. And we will transplant hepatitis C negative recipients with hepatitis C antibody positive, as long as they consent to it, as long as their hepatitis C RNA is negative. At the moment, we will offer hepatitis B positive donors to hepatitis B positive recipients with consent, with the hepatologist approval. At least that's there in our policy. I don't think we've actually done that. And when we get deceased donor transplant offers in the middle of the night, if there is any high-risk behavior, we will get NAT testing, nucleic acid testing for hepatitis B and hepatitis C before accepting the deceased donor offer. So that's the extent of our experience. There may be centers that have done hepatitis B positive to positive transplants, but unfortunately, we don't have experience in them.
Okay. Another question is, what is your opinion on the risk of recurrence of HIV-associated nephropathy in graft? And also in the risk of post-transplant malignancy increased in HIV-positive patients compared to HIV-negative patients?
Yes, the excellent questions. So the time frame didn't permit a detailed review of malignancy, but obviously patients who have a prior history of malignancy need to be monitored very closely, not just for HIV-related malignancies, but for the development of malignancy in general. Now, the few papers that I reviewed, besides opportunistic infections, did not seem to indicate an increased risk for malignancy. I would recommend ongoing monitoring, however, for patients long-term, just because of the hypothetically increased risk, but that doesn't seem to be borne out in the small number, the 75 or 100 transplants that have been performed so far.
Thank you. Dr. Jacqueline Shaw from Mimbili, she's asking, if recipient is unwilling to disclose his positivity to his prospective living kidney donor, is that okay to proceed? Is it a must to disclose?
Yeah, so quite an interesting ethical question. So the way we have avoided conflicts between the donor's history and the recipient is to keep our teams separate. So the donor is evaluated by a separate donor team with a separate donor nephrologist, and the recipient has their own team with the recipient nephrologist. So first and foremost is donor safety. And so the donor safety has to be evaluated by the donor nephrologist. Now, if the donor nephrologist determines that it is safe for the living donor with HIV to donate, then again, we have not done these transplants at our center, but my belief would be that it has to be disclosed as part of informed consent. So with HCV, with hepatitis B, with even things like unknown sexual history or even unknown travel history, we're labeling these deceased donors as exceptional distribution kidneys. And so we're asking our recipients when they're called in for their transplant that this donor is considered exceptional distribution. And so these patients have to sign that consent form. So what we'll tell them is that we believe this kidney is a very good kidney. It's going to perform well, but based on Health Canada criteria, we're calling this exceptional distribution without disclosing the actual details of the infection. And once they're transplanted, we monitor their infection status. So we monitor for hepatitis B, hepatitis C, HIV every 3 months for 1 year afterwards. If you have a donor who doesn't want their status to be disclosed to the recipient, I can see that being a problem. Because at least in the initial stages, I think full informed consent is required beyond the standard exceptional distribution consent.
And we have another question that is asking, any data on long-term outcome among HIV positive donors? Are they at higher risk of nephropathy?
So the last slide in my presentation, and I'm happy to share this with everybody, shows that the initial results in donors is encouraging. Of course, long-term data is required. The overall risk of end-stage kidney disease is still very, very low. Even if you look at the Black HIV positive donors, it's still 13 or 15 or something per 10,000 over 9 years. So you are removing half their nephron mass. So if they develop HIV nephropathy, they will progress to end-stage kidney disease sooner, may progress to end-stage kidney disease sooner, but it certainly will not cause HIV nephropathy. So certainly goes into the informed consent process for the living donor, but the initial data, I would think, is encouraging.
Thank you. So finally, can I hand over the session to Dr. Lloyd Vincent? I know he has one question he can ask, and he can continue with the discussion and closing remarks.
I think no, one last question. Has COVID complicated these recipients? I mean, transplanting HIV recipients?
COVID has not complicated HIV per se, because the number of HIV patients we transplant is so small. But I can speak to COVID more generally, and that is that we are transplanting patients in the COVID era. We unfortunately, our transplant ward is a bit promiscuous, because as you probably know from working on our ward, we admit patients from general nephrology, dialysis, even other patients, endocrinology and general internal medicine will sometimes admit to our ward. And so we're always worried about nosocomial COVID infection. So we have had one patient who died from nosocomial COVID infection late in 2020, before vaccination became widely prominent. I would probably insist that an HIV positive recipient receive the COVID vaccination full course before we transplant them. Now, this is a whole different topic that I'm happy to entertain questions on, but some transplant centers like Toronto General insist that transplant candidates be fully vaccinated, otherwise they will not be transplanted. At our center, we do not insist, we strongly encourage, but we do not insist on full HIV, on full COVID vaccination before accepting them for transplantation. But patients have to understand that they may be turned down when they're called in if there is an outbreak of COVID on the ward or in the hospital, and if there is a new wave that is emerging. So with HIV, I can only see that being more problematic.
Thank you so much, Dr. Ramesh, for this wonderful presentation, and it is so detailed. And we hope that you can send us some slides on a PDF format if it's possible, so I can distribute it if possible. And of course, the video will be up on YouTube in a couple of weeks' time. It's such an important session. And the other thing is, I don't know whether we could actually link up in sort of some way if there are centers interested in doing HIV transplants for some advice from your end.
Sure, yeah. I mean, of course, every collaboration starts once you identify the first patient. And so, yes, I would be happy to find an infectious diseases colleague here who's interested, and potentially a hepatologist colleague as well. But it all starts with finding the first patient.
Yes.
Now, I know we have some people attending from South Africa. They have far more experience than we will ever have with HIV positive kidney transplantation or using HIV positive donors. So that would be another route for collaboration as well.
Sure. think Dr. Bima is here.
Hi, I'm sorry. Now I'm on the pediatric side, so we haven't done any pediatric donors with HIV positive. But we have one or two in the pipeline. The problem is that the parents are not a match, ABO match, so we can't use them as donors, although no, they are virally suppressed, etc. So on the pediatric side, I'm afraid I don't have much. But yes, the program in Cape Town is progressing. But at the last local meeting that we had, one of the nephrologists made the point that although the short-term outcome was very good when they're following these donors up, etc., many of them are starting to show not signs of rejection, but signs of recurrence of the disease like FSGS in the biopsy kidney. It's early and it's not affecting the function much, but that's what they are starting to see. They haven't reported on it, so I'm just giving you some information that she said it's suggestive. It's not conclusive as yet. So that's something to do. You know, they are doing protocol biopsies on these patients. See? So that should be published soon.
Yeah, I think these are two very, very different patients. Those who have HIV infection but end-stage kidney disease from another cause.
Yes.
And those who have end-stage kidney disease from HIV nephropathy.
Yeah.
So those who have end-stage kidney disease from HIV nephropathy are going to be more difficult post-transplant.
Yeah. It's difficult because, you know, we see high incidence of FSGS and we see high incidence of HIV. Well, we used to see high incidence of HIV. So you don't know whether the FSGS is, HIV is incidental to the FSGS or whether it's causing the FSGS in some cases. Of course, if you see the collapsing glomerulopathy, then it's much more suggestive of the HIV. But I must say in the pediatric population, you know, the collapsing glomerulopathy is pretty rare. Okay, it's not as common as what we see in the adult population. So what we see is the NOS, not otherwise specified form of FSGS, even with HIV. And we published on that.
If there are no more questions, I think we'll call it a day. Thank you so much, Dr. Ramesh, for this wonderful presentation and such a detailed presentation. And we really hope that there will be centers out here now who would start into transplanting HIV. And of course, that is East Africa. South Africa is already way ahead, and that's something we hope that some of the centers are actually interested in. Probably in the next few years would start out. So thank you so much, Dr. Ramesh, for all the time that you spent, and it's wonderful memories of Toronto for me. I sometimes hope to come down there for some rounds, and I look forward to meeting up as well. But I would like you're most welcome to Africa anytime you can make time, and of course, give us some sessions out here when you come as well. Thank you very much for accepting this and coming into Africa and giving us so much time and so much of discussion.